Good morning, ladies and gentlemen. Today's lecture is actually in continuation with my lecture last week and is covering the arthropod-borne diseases. In today's lecture, I'm going to discuss the diseases that are caused by ticks, fleas, bugs, cutaneous MYIASIS, and other arthropod-borne diseases. So the first disease I'm going to discuss is Demodex, which is due to the follicle mite. Demodex follicularum, the follicle mite, is an obligate parasite of human pilosebaceous follicles. The mite measures 0.3 to 0.4 millimeter in length and has an elongated, striated abdomen, giving it a worm-like appearance. So in length and in diameter, it is perfect to fit into the follicular orifice. The Demodex follicularum occupies the hair follicle, and the smaller Demodex brevis, sebaceous and meibomian glands. Lifespan of Demodex follicularum is thought to be approximately 2 weeks, and the heart-shaped eggs hatch to produce a hexapod larva, and the 8-legged adult develop in vivo after 2 nymph stages. So this is the shape of adult Demodex mite. The Demodex follicularum assumes a head-down position in a follicle, often with tip of the abdomen protruding from the follicular orifice. You can see here. This sometimes is visible on the skin as well. The follicle mite are quite mobile and migrate from follicle to follicle. Most infested follicles contain 2 to 6 mites, but occasionally they are much more numerous. So you can see this follicle, this contains 1, 2, 3, 4, 5, 6, 7 mites. And in this cross section, you can also see the cross section of 3 mites in a follicle. So the follicle mite show a predilection for areas of high sebum production, and they have been shown to contain lipases. They are most numerous on forehead, eyebrows, eyelids, cheek, nose, and nasolabial fold. So here there is an interesting comparison. The mite due to scabies avoid those areas which are rich in sebaceous glands, and this follicular mite is seen, it is predisposed to the areas where there is high sebum production. The prevalence of both Demodex follicularum and follicularum brevis increases with age. The skin surface biopsy technique is a useful method of assessing the population density and distribution of Demodex mites. New imaging techniques such as high-definition optical coherence tomography or confocal laser scanning microscopy may be helpful for in vivo detection of Demodex mites. Pathophysiology. Demodex follicularum has been implicated in pathogenesis of a condition which is called as pityriasis follicularum. This was originally described as occurring predominantly in middle-aged or older women who rarely wash their faces but use large quantity of makeup and cleansing creams. This dermatosis is characterized by diffuse facial erythema, follicular plugs, vesiculopustules that impart a nutmeg greater appearance to the skin. This is a kind of a grater, an instrument which grinds the nutmeg. Again, you can see the picture you can Google the picture of this nutmeg grater, and the skin looks like it. Then The role of Demodex and Rosacea. The question of pathogenic role of Demodex mite in rosacea has always been debated, although the skin surface biopsy have shown statistically significant increase in density of Demodex mite in the facial skin. And it is also an observation that most rosacea patients have an oily skin, and since the rosacea as well as Demodex mite is seen more in later ages than younger ages, so this thing is also very common. It has been suggested that a local delayed hypersensitivity response to Demodex antigen and bacterial antigens associated with Bacillus olyronis isolated from Demodex follicularum have the potential to stimulate an inflammatory response in patients with papillopustular rosacea. Then a view that a beneficial effect of metronidazole gel or metronidazole tablets in treating rosacea might be mediated through action against the Demodex mite. Clinical features. Rosacea-like eruption in which large number of mites could be demonstrated and which respond to therapy with acaricides or metronidazole is described. Demodex has been implicated in the causation of papillar and papillopustular lesions in immunosuppressed individuals, including children with leukemia, a patient with tumor stage mycosis fungoides, and patients with HIV infection. Other presentations include a localized scaly patch, pityriasis follicularum-like lesions, and scalp lesions mimicking nevus. The Demodex is present in eye flash follicles and has been implicated in pathogenesis of blepharitis in some patients. Treatment. First of all, the home treatment and prevention strategies that include using mild shampoo on hairs and eyelashes every day, cleansing the face twice daily with a non-soap cleanser, avoiding oil-based cleansers and greasy makeup, exfoliating periodically to remove the dead skin cells. Then the treatment with acaricides, and the options include benzyl benzoate solution, permethrin cream, sulfur ointment, crotometon cream, selenium sulfide wash, metronidazole gel, salicylic acid cream, or ivermectin cream. In severe cases, such as those with HIV infection, oral ivermectin may be recommended. Oral ivermectin may be useful as a complement in the treatment of Demodex follicularum infestation with ocular manifestation. Now, the second disease to be discussed today is the skin manifestations by infestation by the class Chilopoda, centipede, and diplopoda, which is multipedes. Chilopoda is a class with approximately 2,500 known species of chilopods. The common chilopod is a centipede, which is a terrestrial, nocturnally active, and cavernous worms. The centipedes are elongated arthropods with bodies composed of many segments, each bearing one pair of legs. The first pair of legs is modified and provided with powerful hollow claws, which are used to grab the prey and inject venom from the poisonous glands in the basal segment of the legs. Clinical features. The claw of smaller species of centipedes are unable to penetrate the human skin, but some tropical and subtropical species can inflict painful bites. Generally, it does not bite, but sometimes it can inflict bites. The bites cause local pain, erythema, and edema, which may persist for several hours. The bites may sometimes lead to necrosis. Systemic symptoms include nausea, dizziness, and pyrexia. Secondary infection is the major complicating factor of the envomation, the management. The site should be washed with soap and water to reduce the risk of wound contamination. Cold compresses and analgesia will help with pain control. Then Millipedes. Diplopoda is a class of approximately 10,000 known species of diplopods. The common diplopod is a millipede, which is again a terrestrial worm on the forest floor. Millipedes also have multi-segmented bodies, and most segments bear 2 pairs of legs. So centipede has 1 pair and millipedes have 2 pairs of legs per segment. They feed mainly on the decaying vegetable matter and are generally regarded as harmless, but some large tropical species can cause injury to humans when acting defensively. Millipedes have numerous repugnatorial glands which are distributed along the body segment, which provide a chemical defense system, and it is the corrosive secretion of these glands which may cause burns or allergy on the skin. The millipede secretions contain benzoquinone and hydroquinones. Clinical features. Children often try to pick up their millipedes and are therefore at most risk of burn from these corrosive defense secretions. So millipede secretions enter the eye and produce severe irritant conjunctivitis. Contact with the skin produces a local burning sensation and yellowish brown staining, which gradually darkens to deep mahogany or purple brown. The lesions blister within a day or two, but in absence of secondary infection, will heal and deesquamate in 10 to 14 days. So it gives a look of acid burn. The discoloration may persist for months. The management. Skin lesions should be washed with copious amount of water to remove any remaining secretions, and area cleaned with alcohol, which is a solvent or benzoquinone if available. The blister should be treated with topical antiseptics. Ocular injury should be dealt with ophthalmologists because severe envomation can result in blindness. Now the ticks, the diseases that are caused by ticks. Ticks are also known as the acari. Ticks are large acarines which are the blood-sucking ectoparasites of vertebrates. They are important vectors of diseases such as tick-borne relapsing fever and a number of viral, rickettsial, and borrelial infections that include Lyme's disease. Tick possesses a mouth part that is referred to as capitulum, an unsegmented body, and 4 pairs of legs in an adult. The larval ticks have 3 pairs of legs. You can see the 4 pairs of legs, 1, 2, 3, 4 here. There are 2 major families, the Ixodes, which are the hard ticks, and the Ergacidae, which are the soft ticks. Ixodid tick have 4 stages in their life cycle: the egg, larva, nymph, and adult. The larva and nymph require blood meal before further development can occur, and adult female also require blood meal before egg laying. Female tick lay 1 large batch of eggs and then dies. Some Ixodids use 1 host for larval, nymphal, and adult stage, 1 host tick, whereas others require 2 or more usually 3 separate hosts for every stage. The most ticks are essential parasites of wild animals, and humans are only the incidental hosts. When attaching itself to the host, tick uses its toothed Glyceria to cut into the epidermis before thrusting the hypostome into the opening and gradually penetrating the dermis. So these are a few ticks. This is a deer tick, this is a dog tick, and this is a Loester tick, and are the further shapes of the nymph and adult male and female shapes. So this is the normal shape of a tick, and this is the shape once the tick has taken a blood meal and its abdomen is distended by this engorged blood meal. In case of exotic ticks, it is usually the parasite itself that attaches the patient's attention. Larvae, nymph, and adults may be discovered attached to the skin, and humans usually become accidental hosts. Bite from soft ticks may be particularly painful, and the color of engorged tick has led patients to suspect that they had melanoma. So this tick, which is attached to the skin, gives impression of a bluish black papule. Acute lesions include erythematous macules, papules and nodules, mild edema, vesiculation, bully formation, leading to tissue necrosis and ulceration. Erythematous plaques may be difficult to differentiate from erythema migrans. The urticarial response to tick have been reported in the berry pickers. Post-inflammatory hyperpigmentation may persist several months after the acute lesions. So symptoms of a tick bite: it can be swelling, pain at the site of tick bite, a burning sensation, rash may blister, and sometimes difficult in breathing, which requires emergency medical intervention. So this is a long list of tick-borne diseases. Tick becomes a vector of several bacterial and parasitic diseases, which include the African tick bite fever, the Mediterranean fever, tick-borne relapsing fever, Lyme's disease, Siberian tick typhus, Australian spotted fever, Japanese spotted fever, tularemia, Rocky Mountain spotted fever, the Crimean Congo hemorrhagic fever, babesiosis, human monocytic ehrlichiosis, human granulocytic ehrlichiosis, southern tick-associated illness, and tick-borne lymphadenopathy, known as Ebola. Management. Removal and identification of tick can be a major step in the management of infectious diseases. Removal of multiple ticks may be difficult, but tick should not be removed with sudden, forcible movement, as this will often leave the mouth part embedded in the skin, which has to be removed again. Best is to remove the tick intact. This can be done with the help of tweezers or special devices. The tick must be gripped as close to the skin as possible, as you can see in the picture, and gentle traction is done to remove the tick. The risk of vector-borne diseases transmission is minor if tick is removed within 24 hours. Application of fingernail, hot matches, or isopropyl alcohol have never demonstrated efficacy in removal. So treatment. Except for the viral fevers and babesiosis, tetracycline is antibiotic of choice for most tick-borne diseases. The delayed antibiotic therapy can be fatal, especially in Rocky Mountain spotted fever. So therapy should be started quickly in cases of fever and headache in endemic areas without awaiting the laboratory confirmation. Prevention. Avoidance of tick-infested areas by use of repellents and rapid tick removal are the key point in primary prevention. The secondary prevention is based on prophylactic antibiotics or rapid institution of antibiotics if symptoms appear. Now we are going to discuss a very common happening whose patients we see daily and many. This is a papillary urticaria or non-specific arthropod bites. The clinical features of arthropod bite are non-specific, so diagnosis relies on the array of arguments, none of which is specific by itself. The most frequently encountered response is the papillary urticaria. It is initially an extremely itchy urticarial wheal that develop at the site of the bite, and this is succeeded by a firm pruritic papule which usually persists for several days. The wheal and papule may show a central hemorrhagic punctum, which is actually the diagnostic point, and the papule may be surmounted by a tiny vesicle. So it is actually a papulovesicle or a punctum in the center of an erythematous papule. Lesions are often grouped in clusters and develop in crops at irregular intervals. So development of lesion in crops does not mean that it's not an insect bite, because sometimes the people are regularly exposed to that particular insect. The number and distribution of skin lesions produced by the bites depend upon the type of exposure and feeding habit of the arthropod involved. So, if the arthropod bites are due to the arthropods which are flying, that are the flying insects like mosquitoes, then these kind of bites will occur on exposed areas like face, like hands and forearms and feet. And in contrast, if the arthropods are the crawling insects like the bugs, then the bites will occur on hidden areas, that is closed areas on the trunk and the limbs. Bullous reactions are common on the lower leg, but may occur in other side, especially in children. In presence of lower limb, venous hypertension, hemorrhagic or ulcerated lesions may develop. More severe local changes are sometimes found with cellulitis and lymphangitis in the apparent absence of secondary infection. Irritation is almost constant symptom, and rubbing and scratching may increase the inflammatory changes and induce eczematization. When bites are very numerous, or if local reaction is severe, there may be fever and malaise. Secondary infection is a common complication and may manifest as impetigo, folliculitis, cellulitis, and lymphangitis. Anaphylactic shock is unusual except with Hemantoptera stings, but occasionally seen with some other arthropod. Prevention. There are several strategies that can be employed in attempts to avoid the arthropod bite stings and arthropod-related disease transmission that include protective clothing, insecticide-impregnated netting, and repellents. This is mainly applicable to the flying insects. With regards to the latter, there are two principal categories, that is, a plant-derived essential oil repellents and the synthetic chemicals. The former group include citronella oil, oil of eucalyptus, peppermint, tea tree oil, lavender, soybean oil, and the neem oil. While synthetic chemicals include DEET and N-diethyl toluamide or N-diethyl 3-methyl benzamide or DEPA or PMD or picaridin. The journal management. local wound care by cleansing, removal of remaining arthropod parts, management of pain and patient discomfort by using ice packs, application of topical corticosteroids, systemic antihistamines, injection of local anesthetics, or sometimes use of systemic analgesics. Then institution of supportive measures in case of allergic anaphylaxis or toxic reactions. Antibiotic therapy in case of secondary infection, and tetanus prophylaxis if necessary. Now, another important disease, which is cutaneous MYIASIS. Traumatic or wound MYIASIS has been a serious complication of war wounds in tropical areas and is sometimes seen in neglected ulcers or wounds in most parts of the world. Cochleomya, hominovorax are the most common flies that cause obligatory human wound MYIASIS. The wound MYIASIS is most often initiated when flies oviposit in the necrotic, hemorrhagic, or pus-filled lesions. That means that the flies lay their eggs in this environment. The most important predisposing factor for wound MYIASIS is the lack of hygiene and poor socioeconomic status. Obligatory cutaneous MYIASIS occur in two main clinical forms. This is the fruncular and migratory MYIASIS. Both occur on exposed skin, often face, scalp, arms, and legs. So the MYIASIS is described generally into two categories. Wound MYIASIS, in which there is already an infected wound and the fly get an opportunity to lay their eggs in that wound, and this is an opportunistic infection, opportunistic infestation, while the second category of MYIASIS is an obligatory MYIASIS in which the fly has to enter the human body or mammalian body for its development. And this obligatory cutaneous MYIASIS is of two types, either fruncular or migratory. In the fruncular form, a boil-like lesions develop gradually over a few days. Each lesion has a central punctum. Posterior end of the larva is usually visible in the punctum, and its movement may be noticed by the patient. The lesions are often painful. The inflammatory reaction around the lesions may be accompanied by lymphangitis and regional lymphadenopathy and systemic symptoms. Secondary bacterial infection is a possible complication. Once larva has emerged or has been removed, the lesions rapidly resolve. The flies causing fruncular MYIASIS in human are Dermatobia hominis, Cutaraba, Cordylobia, Arthropopophaga, or Cordylobia rodeni, and other. So these are the few pictures of fruncular MYIASIS. These are not taken from the net, and these are actually my patients and taken from Sierra Leone, which is a prevalent area where this fruncular MYIASIS fly called as tumbu fly resides. The migratory MYIASIS is a creeping eruption that resembles cutaneous larva migrans, in which a tortuous thread-like red line with terminal vesicle marks the passage of larva through the skin. The larva lies ahead of the vesicle in apparently normal skin. The larva may live for months in the human skin and migrate at the rate of 1 to 30 centimeters per day. This is faster than the cutaneous larva migrants. Infestations may present with pustules, nodules, and recurrent swelling. This form of MYIASIS is produced by larva of a fly, gastrophilus. So these are the images of migratory MYIASIS. Looks very similar to the larva migrants. So this is one of the differential diagnoses of cutaneous larva migrants. Then there is another MYIASIS which is called as the cavitary MYIASIS. Infestations of the natural body cavities is called as the cavitary MYIASIS. Eristalis tenax, a fly called as the drone fly, can cause intestinal, gastric, or urinary MYIASIS. It's an accidental MYIASIS related to the ingestion of contaminated, uncooked food or water containing the fly larvae. Rare cases are mainly reported in India, Africa, and Europe. Management. Follicular MYIASIS. The larva of Cordylobia can often be expressed by firm pressure around the edges of the lesion, but sometimes the punctum may require to be enlarged surgically. The traditional method of treatment, which include occluding the punctum with mineral oil, petrolatum, or butter. Injection of lignocaine or lidocaine underlying the nodule may be sufficient to push the larva out, and forceps may be used to hold and extract the larva, and surgical management is rarely required. So this is the way I used to remove the larva, that is injection of lignocaine at the base of the follicle. Then after some time, as the tip of the larva is seen, it is extracted by means of a dissecting forceps. The larva assumes a head-down position within this punctum. Migratory MYIASIS. After identification of its position, the larva may be removed with a needle. Oral ivermectin or albendazole may be helpful in if extraction is not possible because the larva is too deep in the tissue. The wound MYIASIS require debridement and irrigation to remove the larvae and treatment of the secondary infection. Ivermectin has been used both topically and orally in management of MYIASIS. Ivermectin is not recommended for follicular MYIASIS because it may kill the larva inside the lesion with consequent inflammatory reaction. Now we'll discuss the bedbugs. Bedbugs are 4 to 5 millimeter in length with dorsoventrally flattened oval bodies. Mouth part is modified into proboscis and adapted for piercing and sucking. Bedbugs normally feed at night, usually about an hour before the dawn. They usually fear light and avoid the glossy surfaces. During the day, they hide in dark places like crevices in the furniture and mattresses and peeling wallpaper. Each female lay about 300 eggs in her lifetime. Eggs hatch in about 10 days. Female bedbug deposit their pearly white flask-shaped eggs in the crevices of the floor and wall, in furniture, in bed frames, and in the mattresses. The initial bite is usually not felt because of the anesthetic contained in the saliva of bedbug. Allergic reaction to saliva may sometimes occur late. Although most patients do not have any symptom after the first bite, reactions may occur 10 days later. The most common reaction to bed bugs are pruritic maculopapular lesions centered by a bite visible as an hemorrhagic punctum. So, an important point to remember is that if a patient of suspected bed bite comes to you, then in history, there will be a history of bed bug bite a few days before the lesions become symptomatic. So just remember that. The distribution of lesions may be evocative if the lesions are grouped on a linear or a curve. That is also known as the breakfast, lunch, dinner alignment. However, this pattern of distribution is not specific for bedbugs and can be found in other arthropod infestations. Most of the lesions are distributed on uncovered areas of the body. Nodules, bullous lesion, urticaria are less commonly found. Few cases of systemic symptoms of anaphylaxis is reported. Furthermore, lesions classically disappear when changing the sleeping place. The bedbug infestation is confirmed by the identification of the insect, not requiring the assistance of an entomologist in most cases. So the complications and comorbidities. Secondary bacterial infection, staph or strep, and psychological consequences may be important, leading to sometimes parasitophobia. These are linear marks here as well as here of this bed bug bites. A few blistering lesions are also seen here. And these are mainly urticarial lesions. Management. Topical steroids are used to relieve the symptoms. Systemic antihistamines may be helpful to relieve pruritus. Secondary bacterial infection require topical or systemic antibiotics. Patient education by professionals is fundamental. Detection and identification of arthropod or its fecal traces in suspected areas should be explained to the patients. All life stages of bedbugs may be killed by washing at 60 degrees centigrade, dry cleaning, or tumble drying at 40 degrees centigrade. The pest managers recommend the disposal of infested furniture, physical removal of bedbugs, and vacuuming. Bedbug infestation should be treated by insecticides, mainly pyrethroids. Bedbug resistance to all the insecticides have been demonstrated. In this situation, a combination of available products may be preferred. A second treatment after 2 weeks is often necessary because of the low efficacy of insecticides against the eggs. Wash mattress cover and bed linen at 60 degrees centigrade. Buying a second-hand mattress and furniture must be strictly forbidden. Tungiasis. Tungiasis is caused by a sand flea, Tunga penetrans, also known as the jigger or chigo. Originally a native of South America, is subsequently spread to Africa, Caribbean, and India. Tunga penetrans is the smallest known flea, 1 millimeter long, so barely visible. Its larvae develop in a dry sandy soil, and development from egg to adult takes about 3 weeks. The impregnated female flea burrow into the feet of mammals, preferring human and pigs. Once embedded in the skin, the flea abdomen enlarges to a size of a pea, and large number of eggs are produced. The eggs are subsequently gradually extruded out over a period of 2 weeks, and the female dies and is sloughed off. So this is how a female flea clinches to the skin and gradually enlarges, and the body of the this flea contains several eggs. The presence of flea causes intense irritation. The typical appearance is a black dot surmounted by a halo of erythema. The lesion enlarges to form a mother of pearl colored papules with a central dark punctum produced by the enlarging flea abdomen. In severe cases, feet may be honeycombed by multiple lesions causing serious discomfort and disability. The tungiasis can be a serious health problem in resource-poor communities. The differential diagnosis of this infection can be MYIASIS, verruca vulgaris or wart, ingrowing toenail, acute paronychia, mycotic granuloma, malignant melanoma, and arthropod bites. Management. Best procedure for dealing with tungiasis is blunt dissection of the intact parasite. This can be accomplished by enlarging the surface punctum and extracting the flea with tweezer, curettage, cautery, or excision. Those visiting the endemic area should be warned to wear stout shoes and not to sit on the ground. So this ends my lecture today, and hopefully seeing you next time with another edition of my lecture. Goodbye and have a good day.